molecule is available with us is pretty long time. So initially for 3 to 4 minutes, I've got one video film that I'm going to be showing it to you to give you some brief idea regarding the molecule and its properties. And followed up, we are going to be talking about the immunotherapy in the oncology, like where the clinical studies I'm going to be discussing, which have been done upon the various malignancies, including the advanced non-small cell lung cancer, the superficial bladder carcinoma, head and neck tumors, and all of them. So shall I start?
Yes, sir.
Great.
The air we breathe, the happiness we share. Imagine it all coming to an end. Imagine the cruel hands of a deadly killer snatching it all away. A killer named cancer. Cancer, the dreaded C word. Lung cancer, the most dreaded of them all. Lung cancer is the major cause of cancer-related deaths worldwide. More than 100,000 people are diagnosed with lung cancer every month. Much more than any other type of cancer. How does cancer develop? Immune evasion leads to cancer development and progression. Increased immunosuppressive mechanism leads to decreased immunosurveillance. Current therapy. All effective therapies improve immune function. Chemotherapy decreases immune suppression, increases immune activation, and is synergistic to immune therapy. Desmocollin 3, DSC3, is diagnostic of squamous non-small cell lung cancer. Chemotherapy converts DSC3 negative to DSC3 positive cells. It is also expressed in other cancers like melanoma, colorectal cancer, besides many others. The emerging treatment, Mycidac-C. Mycidac-C is active immune therapy targeting DSC3 expressing cancer. Mycidac-C activates immune cells and expresses DSC3 on their surface. Mycidac-C reduces immunosuppression by its effect on immunosuppressive cells and cytokines. It preferentially kills DSC3 expressing cancer cells. Mycidac-C provides synergy to chemotherapy. All this backed by solid research and innovation. Randomized controlled clinical trials have been conducted wherein Mycidac-C is added to standard chemotherapy to evaluate its safety and efficacy. Research studies have proven that addition of Mycidac-C does not add to toxicity. Addition of Mycidac-C improves response rate. Addition of Mycidac-C improves overall survival probability by 28.2%. Improvement in survival in squamous non-small cell lung cancer NSCLC is 43.5%. This is significantly better than most other therapies. The future, Mycidac-C, a game changer in the treatment of lung cancer. Cadila Pharmaceuticals' extensive research relating to the treatment of lung cancer has brought a smile to many a face. All this would not be possible but for the vision, persistence and foresight of Shri I.A. Modi. His thinking was very clear. Anything that can add to a moment of life and make it more meaningful is definitely worth the effort. Mycidac-C offers that hope for life. Mycidac-C is the first active immunotherapy targeting DSC3. It can be used as a standalone for small tumors. It works in synergy with chemotherapy for large tumors. Mycidac-C, the revolutionary game changer for treating lung cancer.
Thanks for paying attention here. So let us come to the presentation here. I hope this is visible to you, Ujjwal. Okay, great. So this is a presentation on the topic of immunotherapy in the cancer. So this is a history related to the usage of the chemotherapeutics and immunotherapy in the field of oncology. So when I talk about the chemotherapeutics, like they started with the discovery of the nitrogen mustard in 1942, followed by methotrexate, vincristine, doxorubicin, and cisplatin and many more chemotherapeutics. When I talk about today's era, we are using lots of the tyrosine kinase inhibitors, including the imatinib for various malignancies. But when I talk about the history of the usage of the immunotherapy in the field of the oncology and other fields, it is not very old in comparison to the chemotherapy. It started with in 1986 with the discovery of the interferon alpha, followed by the non-specific immunotherapies like the BCG, which we are still using for the therapy of superficial beta carcinoma. Then HER2, positive breast cancer cases, we are using trastuzumab, followed by CAR T cell therapy. And in 2013, we got the approval of Mycidac-C for the cases of advanced non-small cell lung carcinoma. So, to talk further here, this is regarding the immune mechanism and the cancer. So, as we do understand, this escape phenomena is there, and there is a lack of the positive signals are there, which is making these tumor cells to be naked, make them escape the immune system, and ultimately they are not being captured by the T cells of the human body. And definitely there is a immunosuppression is there. So what we people are doing in the by the usage of immunotherapy, we are making the T cells to be more active so that these tumor cells they can be recognized and they can be killed by the T cells of the human body. So to talk further here, this is the effect of the Mycidac-C immunization on the immune cells, T cells, and the effector function. So if I talk about the left side graph here, uh, showing the single injection is going to be creating the desmocolinity on the surface of the immune T cells, and giving the multiple injections of Mycidac-C will be creating the more levels of desmocolinity on the surface of T cells. So Mycidac-C induces the expression of the desmocolinity on the surface of T cells, and when I talk about the right side picture here, the effector function after the 2 hours, and which shows that desmocolinity positive squamous cells and non-small cell lung carcinoma cases, they're going to be cancer cases, they're going to be having the more cytotoxic effect because of the T cells. So Mycidac-C induces the immune cells to kill desmocolinity expressing T cells. But when I talk about the desmocolinity negative adenocarcinoma and other histological varieties, they don't have so much of the cytotoxic effect. So as seen in the case of adenocarcinoma, the desmocolinity expression is not so much in comparison to the squamous varieties. So there is barely any cytotoxic effect seen here. So to talk further here, this is the slide to tell upon the chemotherapy and desmocolinity. So chemotherapy do convert desmocolinity negative cells to the desmocolinity positive. So after giving the uh, uh, cisplatin chemotherapy as in chemotherapy, paclitaxel, doxorubicin, gemcitabine, they are going to be making these tumor cells to express the desmocolinity. And desmocolinity negative cells, they do express the desmocolinity following the chemotherapy. And this has also been shown even in the subtherapeutic doses. So to talk further here, to summarize the mode of action of Mycidac-C, that is heat kill micro W, first it induces the expression of desmocolinity on the surface of T immune cells, and desmocolinity expressing immune cells, they do kill the desmocolinity expressing cancer cells. So desmocollin-3 is a marker for the squamous variety of the non-small cell lung cancer, which I'm also going to be elaborate in further few slides. And last but not the least, in desmocollin-3 negative cells express desmocollin-3 following the chemotherapy, even in the subtherapeutic doses. So these are the details regarding the product Mycidac-C. It is an innovator product from the Cadila Pharmaceuticals. It is available with us only, and no other company has been involved in the sales and marketing of this Mycidac-C. Secondly, it is an immunomodulator. It is having the strong immunomodulator activity, and it is available as a pre-filled syringe, which is containing zero point 0.2 ml of the heat kill micro W, and each zero point 0.1 ml is containing the heat kill micro W with a strength of zero point 0.5 multiplied by the 10 to the power 9 bacilli. And here sodium chloride has been added here as an excipient. And when I talk about the preservative here, it is containing very low quantities of the thiomersal. So this is the information regarding the sites of administration where the Mycidac-C can be given. So it is available to be given by the intradermal route. So over the deltoid region it can be given, and the second side being the suprascapular region it can be given, and around the umbilicus periumbilical region again the injection can be given, and it can also be given upon the fourth side, that is the inner part of the thigh. So this is a slide to tell you about the direction of desmocollin-3 expression on the tumor cells. So this is immunohistochemistry using the commercially available antibodies here. So we show the desmocollin-3 expression. So this is a slide which I was talking to you, which is differentiating the levels of desmocollin-3 in the histological varieties such as the squamous, adeno, large cell. So when I compile all of the data from these seven published research papers from Worth et al., Kim et al., Tetsumer, Sutain, Monica, Rigi, Sakai. So if we see upon the first column here upon the squamous variety, here the desmocollin-3 expression positivity is much more in comparison to the adenocarcinoma. So when all of data from all of these seven studies, if we are going to be combining, we are able to see like 86.25% of expression of desmocollin-3 over the surface of these tumor cells in the squamous variety. But when I talk about the adenocarcinoma, there is only 0.45% of expression is seen. When I talk about the large cell carcinoma, here it is 11.22%. So desmocollin-3 is said to be, is proving that desmocollin-3 is a marker for the squamous variety of non-small cell lung cancer. To talk further here, I'm going to be talking about the clinical studies uh, which have been done upon the Mycidac-C in the patients of advanced non-small cell lung cancer. So this was the initial pilot study which has been done. It was open label, randomized controlled clinical trial of desmocollin-3 targeted toll-like receptor agonist Mycidac-C in the advanced non-small cell lung cancer cases. So post randomization in the chemotherapeutic arm, the as in cisplatin 75 milligram per square meter of body surface area, the cisplatin was used, and along with that, etoposide was used with a dose of 100 milligram per square meter of body surface area for the 6 cycles. And in the chemoimmunotherapy arm, along with the chemotherapeutics, the Mycidac-C was used for these cases. And the dose was 0.1 ml every fortnightly for the period of 6 months. The injection was used. So these are the patient characteristics in these patients. So both of the arms, test and control arm, they were similar in nature with respect to the age of the patients, sex of the patients, a Karnofsky score, performance status, and as well as the stage of the disorder. So all of these patients, they were actually being suffered from the advanced disease, that is a stage 3B or the stage 4 disorder. So this was the outcome of this clinical study. Like when I talk about the response in the immunotherapy arm, there was the 11% better response was seen in comparison to the chemotherapy arm, where it was only 27%. When I talk about the progression of disease, here the 19% of the patients they actually progressed with the disorder, which was 8% lesser in comparison to the control arm here, where it was 27%. So this is regarding the adverse reactions like with respect to the pneumonia, chest pain, asthenia, vomiting, thrombocytopenia, anemia, leukopenia, neutropenia. Either the both of the arms they were equal in nature, or some side effects they were actually being lesser in the immunotherapy arm of Mycidac-C. So this was the approved clinical trial of Mycidac-C, which was open label, randomized controlled clinical trial of desmocollin targeting toll-like receptor agonist Mycidac-C in the combination with paclitaxel plus cisplatin, platinum pentane doublet versus only platinum pentane doublet in the advanced non-small cell lung cancer cases. So in the chemotherapy arm, the paclitaxel with a dose of 175 milligram per square meter of body surface area plus cisplatin with a dose of 100 milligram per square meter of body surface area. Some platinum pentane doublet was used for the each 3 weeks cycle duration. And in the study arm, along with the platinum pentane doublet, the Mycidac-C was being used. So with a dose of zero point 0.2 ml 1 week before the start of first chemotherapeutic cycles, and for the subsequent cycles, only 0.21 ml on the 8th and 15th day the injection was repeated. And for subsequent cycles, only 2 injections of 8th and 15th day were being repeated. And these patients continued for the 4 chemotherapeutic cycles. So analysis was being done, and overall survival probabilities and the progression-free survival was being noted, and the chi-square mental test were being applied here. And all the adverse deviations they were being noted in the terms of percentage proportions, serious as well as the adverse other uh, side effects. Even the local reactions were being noted here. So eligibility was same, like all these patients were suffering from the stage 3B or the stage 4 non-small cell lung cancer, and both of the arms they were equal in nature with respect to the age, like 18 plus. Eco criteria was 0 to 1. Life expectancy was 24 weeks or more, and hematological parameters were in control, like absolute neutrophil count with the neutrophil count of 1500 or more than 1500 per cubic millimeter of the blood. Platelet count was 1 lakh or plus. Hemoglobin was 9 plus, and same with the hepatic functions and renal function. And the pregnancy was ruled out with a negative pregnancy test, and all these patients were asked to sign the informed consent. So this is regarding the demographic characteristics of both of the arms. So both of the arms were similar in nature with respect to the age, gender, echo criteria, uh, stage of the disorder. So both of the arms were having the patients of uh, both of these characteristic patients were included for the study. When I talk about adenocarcinoma, again, the adenocarcinoma patients, squamous cell variety, uh, other, other histological varieties, even the large cell patients were recruited for both of the arms. And when I talk about the progression of disease, it was found to be 7 patients in the Mycidac-C arm. In the control arm, there are 5 patients who actually progressed with the disorder. When I talk about the death, the 90 patient they actually had the death in Mycidac-C immunotherapy arm, and there were more number of patients they died in the chemotherapy arm, platinum pentane doublet arm, and patients who actually uh, withdrawn the consent and lost to follow, there were 24 in Mycidac-C arm, there were 19 in the chemotherapeutic arm. So this was the outcome of this clinical study. Uh, when I talk about the overall survival, here it was seen to be 10% better versus the platinum containing doublet arm, and the progression of disease they were 11% with the Mycidac-C arm, and 16% patients they were in the control arm chemotherapy arm. So 3 cases of complete response they were seen with the Mycidac-C arm, none in the case of the control arm. So it was concluded that addition of the Mycidac-C improves the response rate in the such group of the patients. Sorry. So this is regarding the Kaplan-Meier curve of progression-free survival in the patients who completed the 4 cycles of chemotherapy. So when I talk about the progression-free survival, it was found to be 96 days better in the Mycidac-C arm versus the control arm, with a hazard ratio 0.43 in these patients. So this is regarding the Kaplan-Meier curve of patients who complete the 4 cycles of chemotherapy as an overall survival patients. So median survival time was seen to be 299 days with the immunotherapy arm of Mycidac-C, which was 66 days better with the platinum pentane doublet arm. So here the hazard ratio was found to be 0.64. So this is regarding the overall survival in the patients of squamous cell carcinoma who complete the 4 cycles of chemotherapy. In the Mycidac-C arm, it was found to be 100 days better, 110 days better versus the chemotherapy arm, where it was found to be 254 days only, and the hazard ratio was found to be zero point 0.4 in these patients. So this is regarding the hematological toxicities in the both of the arms. So anemia, leukopenia, neutropenia, both of the arms, they were seen to be equal in nature. When I talk about the non-hematological toxicities, again, both of the arms, they were similar in nature with respect to dyspnea, diarrhea, nausea, vomiting, fatigue. But so it was concluded that Mycidac-C is not been associated with any kind of the rise in the systemic side effects. But some cases of the injection, local site injection reactions were found after the conduct of the clinical study. It was noted out. So to conclude here, Mycidac-C is synergistic to the platinum pentanoic doublet. It improves the progression-free survival with the hazard ratio of 0.43. It also improved the overall survival with the hazard ratio of 0.64. And in the squamous variety of the non-small cell lung cancer, the hazard ratio was found to be zero point 0.4. And the therapy has not been associated with any kind of the systemic side effects. So this clinical trial was already, this has already been published in the Annals of Oncology by Dr. C.P. Chandrapalani. And our R&D director, Dr. Bhaklesh Kumar, is also available with us here. So welcome to you, sir. So he also published this clinical research paper as an author. So to conclude here, like superb analysis, the improvement in the median survival by 127 days was observed in squamous non-small cell lung cancer with the immunotherapy with a hazard ratio of 0.55. And in patients receiving the planned 4 cycles of chemotherapy, there was an improved median overall survival by 66 days in the chemoimmunotherapy group compared to the chemotherapy group. And this was associated with the improvement in the survival by 17.48% at the end of the 1 year in the chemoimmunotherapy group. And the systemic side adverse events were identical in both of the arms. So this is the slide to tell you about the other clinical studies which have been done in the with the Mycidac-C arm, and where the some clinical trial data has already been generated here, which I'm going to be showing here. So these tumors also express a desmoglein. They include bladder cancer, ovarian cancer, colorectal cancer, malignant melanoma, meningioma, CA tongue, and head and neck tumors. So this was presented in ASCO meeting. Uh, which states like median overall survival was 236 days in the control arm and was improved to by 59 days to 295 days in the KD05 arm with a hazard ratio of 0.55, which was the earlier brand name of Mycidac-C. There was no significant difference was found in the terms of adverse degradations. So this was uh, uh, presented in medical oncology. So addition of the KD05 to paclitaxel plus cisplatin in the patient with advanced non-small cell lung cancer is safe and results in the improvement in the progression-free survival as well as the overall survival. So this was another one which was published. So high compliance rate was observed in the patients receiving the KD05. It improves the response rate and median survival where the administration is as an adjuvant to the chemotherapy. So this is regarding the clinical study which has been done upon the patients of head and neck tumor. So it is published in the ARC Journal of Cancer Science, a comparative evaluation of micro W vaccine based immunotherapy plus concomitant chemoradiation versus the concomitant chemoradiation alone in the locally advanced head and neck cancer. So in this study on the Indian locally advanced head and neck squamous cell carcinoma patient says that the use of the weekly micro W vaccine plus weekly cisplatin is safe and micro W with concurrent chemoradiation therapy may be superior to the concurrent chemoradiation alone in the terms of better response rate, higher local region control with a lesser toxicity. So side effects they actually were found to be lesser with the usage of the Mycidac-C. So this is another one which was published by Dr. M.C. Pant. So immunotherapy may be useful as an adjuvant therapy in the head and neck cancer patients receiving the radiotherapy with better clinical response, reduction in the side effect, improvement in the quality of life. So this also been done in the patients of superficial bladder cancer. So a clinical trial of intradermal toll-like receptor agonist KD05 for BCG recurrent and unresponsive non-muscle invasive bladder cancer. So with the 20 patients with non-muscle invasive bladder cancer received the intradermal KD05, which is the earlier brand name of Mycidac-C. Recurrence-free survival at 15th and 30th month was 35%, in patients. The median refractory recurrence-free free survival was also better for BCG unresponsive compared to the BCG recurrent group with a hazard ratio of 0.3 to 9. DSC3 expression was present in 68.80% of patients, and tumor infiltrating lymphocyte and recurrence-free survival beyond 30 months was seen 2.3 times and 2.8 times more often in the DSC3 expressing non-muscle invasive bladder cancer respectively. So with this, I would like to conclude here and would request to would invite you to raise queries here. Dr. Bharadwaj and Dr. Akhil, hello?
Yes, sir. There.
Yeah.
So I would request you to send me the full papers of the article. I'll just go through it again.
Surely, that definitely I'll send. Definitely I'll send.
Done, sir.
Any questions here?
Sir, was this what happened exactly after 4 cycles of chemotherapy? Because it was mentioned Mycidac-C was continued up to 6 months. So was it administered in patients?
6 cycles and 4 cycles. Then for the period of year, yeah.
So following 4 cycles, it was given once monthly.
Once monthly, okay, sir.
Till there was a disease progression.
Till disease progression, okay, sir. Okay, sir. Any reason for specific site, sir? Specific site of administration?
Yeah. So basically, this product has to be given intradermally or intravenously.
Okay.
So for an intradermal injection, there are sites which are well-known sites for intradermal injection. So we are following those sites. So the sites which are mentioned, so on the upper arm over deltoid or suprascapular space, around umbilicus and around thighs, these are the sites which are known for intradermal injections of immunomodulators.
Okay.
Essentially, I mean, if you want to go in little deeper, in the intradermal space, you have a maximum amount of antigen presenting cells known as Langerhans cells.
Langerhans, yes.
They are maximum there. And then when you give this small amount of 0.1 ml, because intradermal can't take more than 0.1 ml per site, they take it to the neighboring lymph node. So the sites which are selected should be closer to the lymphatics.
Okay.
So that they can take it to the lymph node and this product gets processed in the lymph node. And following processing in the lymph node, body starts producing active immune cells which express desmocollin 3. So the product itself does not get to the tumor or in the various
Okay. Hello.
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 Kamar sir, you are not audible. I think there is some problem. Connectivity issues.
We did lost him. Yeah, he's here.
Sir, excuse me. Actually, last conversation we missed because of some connectivity issue. Yeah, please, sir.
So I'll repeat. See, intradermal space is chosen because Langerhans cells, which are also known as antigen presenting cells, are maximum in intradermal space. Single intradermal injection cannot be administered more than 0.1 ml. That's a limitation because if you inject more, it comes out. It does not stay because of the tightness of that space. Once you inject that, any drug in the intradermal space, it is taken up by Langerhans cells to the neighboring lymph node. In the lymph node, it gets processed, and after that process is over, body starts producing immune cells which are activated and express desmocollin 3. These immune cells expressing desmocollin 3, which are activated, goes into various parts of the body through various mechanisms. So essentially, drug does not reach to the site of action. It is drug-induced immune cells which goes to the site. And that's the reason even with a small amount, you get maximum benefit and with a smaller amount, I mean, in spite of the fact that it's immunotherapy, you don't get side effect because body will try to do whatever is optimum for the body. So body will control, and that's the reason you don't see any systemic side effects with this product. The only challenge is that this product, when you give intradermal, like any other intradermal product, which stays in the intradermal space, you have a local site injection reaction. To avoid that, the other way of introducing this product is you can give it intravenous, because intradermal, there are two challenges. One is local site injection reaction, and in the medical school, we are never taught how to give intradermal. So the paramedical also does not know that. So it's a challenging. And if you give it little deeper, it goes into subcutaneous space where Langerhans cells are not there. And then the side effect becomes maximal. So if you want to avoid that, you can give intravenous. But since this is a biological product, when you give intravenous, it enters the system in a large amount. To avoid infusion site reaction, which is common with any biological, we suggest that you give dexamethasone 2 cc 1 hour prior to injection of Mycidac-C intravenous.
Okay.
Is it clear, or I mean,
Yeah,
I was not
clear,
audible
sir.
for the part?
No. It's clear, sir.
Yeah.
Dr. Nikhil?
Yes, I'm there.
Yeah, and any questions, Dr. Nikhil?
No, sir, I would like to read the full paper, that's all.
Agreed.
Sure, sir, we'll be providing.
We'll send it.
Yeah, please share the full.
Sir, I am happy to share with you that Mycidac-C is available in HCG. In last week only, we had a very good discussion with Dr. Patil also. And apart from HCG, it is already being used currently in Tata, as well as Medanta, Miot, and many other eminent institutions. Overall, it is the first Indian immunomodulator having backup studies and very good efficacy in NSCLC.
Particularly so, sir, squamous cell carcinoma. See, you don't have significant advances in squamous cell carcinoma, correct? And if you look at a hazard ratio, I mean, it's significantly better in squamous cell carcinoma compared to the other varieties.
So, sir, I request Dr. Bhardwaj and Dr. Nikhil to consider Mycidac-C. It's a wonderful product, sir. We assure you for all backup and technical details and data. And we require a valuable endorsement, sir, for this this product, sir.
Sir.
Yeah. And apart from means squamous, it has already shown its efficacy even in head and neck, as sir has told. So we'll share that details also.
Let me take you a little forward.
Yes, sir.
I mean, from a science perspective, see, basically, desmocolin 3 expressing cells, which are activated immune cells, they do the job, as mentioned in one of the slides. And desmocolin 3 is expressed by bladder cancer, head and neck cancer, melanoma, ovarian cancer, cervical cancer. So there's a whole list where desmocolin 3 is expressed. Now, typically, all epithelial cancer will have a desmocolin 3 expressed or desmocolin 3 being hidden. When it is desmocolin 3 is hidden, and if you provide a therapy, which is effective therapy, at a subtherapeutic dose, desmocolin 3 will come on surface. Okay, so that's the basis, and so we recommend it only for epithelial tumors. We don't recommend it to try it for sarcomas and other things. Okay, so it is mainly for epithelial tumors where desmocolin 3 is expressed naturally or can be induced by giving chemotherapy. So I will not like you to use it for a prostate cancer or ER/PR positive breast cancer, because there is desmocolin 3 which is hidden and is not amenable to conventional chemotherapy. If you want to use that, you have to use demethylating agents because there is epigenetic silencing.
Yeah. In fact, last point I would like to add, currently immunomodulators are the buzzwords. And in fact, a our Mycidac-C is available at a very economical and affordable cost. If you compare the cost with the currently available immunomodulators, where the per cycle cost is more than 2 lakh rupees, our Mycidac-C is less than 5,000. So overall, the costing is also very economical and affordable. So request Dr. Bhardwaj to use in the approved indication as well as in head and neck, as sir has suggested.
Wherever you feel appropriate, wherever you feel that patient is likely to benefit. And if you have a query, send us a query and we will provide our feedback.
Sure, sir, sure. So with this, I would like to thank Dr. Bhardwaj for sparing your valuable time. In fact, we are thankful to Dr. Khamar, who is a practicing clinician and still he's always helps us in terms of one-to-one discussion. Dr. Amit, thank you very much. Dr. Khamar and Dr. Bhardwaj.
Yeah, thank you.
Once again, Dr. Sahab,
Thanks,
thank you.
Dr. Nikhil, Dr. Bhardwaj.
Yeah, thank you.
Good night.
Yeah, good
Good
night.
night.